Today I'm going to be going over chapter 13, which is blood, and that is the beginning of the chapter 6, the cardiovascular system. And so I'm going to bring your attention to the objectives. At the completion of Unit 5, or 6 it should be, the student will, 1, describe the characteristics of human blood, list the functions of blood, discuss the components of blood plasma, identify the types of blood cells and function of each blood cell, and compare and contrast the various blood types and how they're used. So we're going to concentrate on that. There's also very useful information about blood clotting and other information in this chapter, but just keep those objectives in mind as far as learning those components. But the rest of this, the whole chapter will be really helpful for you to understand blood tests, for you to understand blood clotting concerns with people who are taking heparin and Coumadin, concerns with people who have blood clotting disorders. And this will be really very helpful to you in understanding a lot of different diseases and issues. Excuse me. So we're going to look at blood components to begin with. So blood is a connective tissue with the fluid matrix. It is the fluid of life. It's where oxygen and nutrients and all the things that we need are delivered to every cell in the body. It's by the way of blood. And also, it's where things that we don't need or we need to be eliminated is also carried through the body. So the components of this blood becomes apparent when a blood sample is spun in a centrifuge. So this picture illustrates that. So plasma is the clear extracellular matrix. It accounts for 55% of blood. The main component of plasma is water. It also contains proteins, albumin, nutrients, electrolytes, hormones, and gases. Plasma proteins play roles in blood clotting, also in the immune system, and the regulation of fluid volume. Plasma without clotting proteins is called serum. The formed elements include erythrocytes. Erythrocytes are red blood cells. Erythro means red and cytes are blood. We can also call them RBCs. Leukocytes are white blood cells because LEUKO, leuko, means white. And we also call those white WBCs and platelets. They make up 45% of blood. Red blood cells are the heaviest of the formed elements, and they sink to the bottom of the sample. So this percentage of red blood cells in a sample of blood is called the hematocrit, and that's one of the blood tests that we do frequently on patients to see whether they are dehydrated or whether they have too much. What we're looking at is the ratio of red blood cells to plasma. So this will tells us a lot about a patient's condition. So that's one of the blood tests. It's called hematocrit. So white blood cells and platelets form this buff-colored band right here, just underneath the plasma, and it's called the buffy coat. These cells are about 1% or less of the blood volume. And the combination of plasma and blood cells determines the stickiness of the blood. So when the formation of blood cells is called hemopoiesis. Red bone marrow is found in the ends of long bones and in flat irregular bones like the sternum, the cranial bones, vertebrae, and pelvis. And that's where in the red bone marrow, that's where all types of blood cells are made. The lymphatic tissue is found in the spleen, lymph nodes, and thymus gland, and that produces lymphocytes. So let's look at red blood cells. Their principal function is to deliver oxygen to cells and remove carbon dioxide. So red blood cells, their disc-like shape provides a large surface area through which oxygen and carbon dioxide can diffuse. They lose almost all of their organelles during development, and they don't have a nucleus and they don't have DNA, so they can't replicate. They have a life cycle. They're made, and then they live for about 120 days, and then they die. The cytoskeleton of the red blood cell, or what's the cell, or the makeup of the cell, it has stretchable fibers that make it flexible, allowing it to fold and stretch as it squeezes through tiny capillaries and then spring back into shape. And this is very important. And in your book, it talks about sickle cell anemia on page 256, and it's the shape, this flexible shape, is very important, because if you don't have that flexible shape, it can cause clumping or sickling. And so if you, under Life Lesson Sickle Cell Disease, that'll help you to understand the importance of the blood shape. So take a look at that. Hemoglobin, it's more than a third of the interior of a red blood cell is filled with hemoglobin. And hemoglobin is a red pigment that gives blood its color. Hemoglobin consists of 4 ribbon-like protein chains called globins. Bound to each globin is an iron-containing molecule called heme. Each heme molecule can combine with 1 molecule of oxygen. Therefore, one hemoglobin molecule can unite with 4 molecules of oxygen to form oxyhemoglobin. Hemoglobin also carries carbon dioxide, but instead of binding with the heme, the carbon dioxide binds with globin. So how much oxygen the blood can carry depends on the quantity of red blood cells and hemoglobin it contains. So the oxygen binds to the heme portion, and the carbon dioxide binds with the globin. So what is the extracellular matrix of blood? It is plasma. Hemoglobin is the oxygen-carrying component of red blood cells, RBCs. RBCs are one of blood's formed elements, and serum is plasma with clotting proteins removed. So the red blood cell life cycle. If you look on page 257, it has a great picture of this. Also, a great animation on the life cycle of the red blood cell. Please watch this. And like I've said before, if you need to watch it several times, it's be helpful or helping you to understand this. But what happens is that red blood cells circulate for about 120 days. They then die. They break up, and they're consumed by phagocytic cell in the spleen and liver. These cells eat. They eat them. They break them up. The body constantly produces red blood cells to maintain homeostasis in a process called erythropoiesis. And this is what's depicted on this slide, the process of erythropoiesis. The process is maintained through a negative feedback loop. The body, so number 1, oxygen levels decrease. The oxygen levels decline as damaged red blood cells are removed from circulation. Number 2, kidneys detect decreasing oxygen levels, and they secrete a hormone called EPO, or erythropoiesis. The EPO stimulates red bone marrow to create new erythrocytes. Immature erythrocytes, called reticulocytes, are released into circulation. After a couple days, 1 to 2 days, reticulocyte becomes a mature erythrocyte. The increased number of red blood cells causes oxygen levels to increase. Less EPO is produced, and the red blood cell production declines. So this is, we're talking about how hormones can be produced in different organs and in different places. And this is one of those examples where the kidney produces erythropoietin in response to low oxygen in the blood. So please view the animation on the life cycle of the red blood cell. It will really increase your understanding of that. So let's look at the breakdown of red blood cells. This is very important to understanding a lot of different things. Hemoglobin breaks down to globin and heme, and globin breaks down into the amino acids, and heme breaks down to iron and bilirubin. What happens is you have these macrophages, these big eaters in the liver and the spleen. They ingest and destroy old red blood cells, RBCs. In the process, hemoglobin is broken into its two components, globin and heme. Globin is broken down into amino acids, which are used for energy or to create new proteins. Heme is broken down into iron and bilirubin. Iron is used to create new hemoglobin. It's recycled, and bilirubin is excreted into intestines as part of bile. So bilirubin is what gives as when it goes into the bile, it is excreted into the intestines to help break down fat, and also gives the brown color to the stool. So when the destruction of red blood cells becomes excessive, hemolysis, the body can't assimilate the increased amounts of bilirubin. The excess bilirubin enters the tissues, causes the skin and sclera to take on a yellowish hue, which is jaundice. Another thing that happens is that because it's not going in to the bile and being introduced into the intestines that way, you'll see other symptoms like a clay colored or tan colored, very light colored stool, because the bilirubin is not being excreted in the stool, it's being excreted through the skin. Another thing that happens, because it's an excretory organ, is that the kidneys will start excreting bilirubin through the urine, and the urine will get a tea colored appearance. So the bilirubin will stop coloring what it's supposed to be coloring, the stool, and will start coloring the skin and the urine on, because of the body attempt to get rid of it, because it is toxic to the body and the body is trying to excrete it. So please view this animation on the breakdown of red blood cells. So let's look at white blood cells. If you're following along in your book, the white blood cells talks about white blood cells on, well, we've got, as I'm turning pages here, 258, the breakdown of red blood cells, 259, things to help you to understand the importance of red blood cells, and on page 259, it talks about polycythemia, it talks about anemia. It says the fast fact: to ensure adequate erythropoiesis, the creation of red blood cells, we must consume 5 to 20 milligrams of iron in our food every day to cover the amount lost through the urine, feces, and bleeding. And packaging hemoglobin inside red blood cells ensures that the hemoglobin remains within the confines of the blood vessels instead of leaking out into the surrounding tissues. So really interesting things in your book that will help you to remember these important things. Remember, in our objectives, we're describing the characteristics of human blood. We talked about that, talked about plasma. We're listed the functions of blood, discussed the components of blood plasma, and identifying the types of blood cells and function of each blood cell. So that's where we are now. We're moving on to the white blood cells, and they're called leukocytes. They're the fewest of the formed elements. The body contains 5 types of white blood cells, all different in size, appearance, abundance, and function. They all contain a nucleus. They contain other internal structures that look like granules when stained and examined under a microscope. Granulocytes have obvious granules. Agranulocytes have few or no granules. So that's how we can differentiate them. Granulocytes contain a single multilobular nucleus. The 3 types of granulocytes are neutrophils, eosinophils, and basophils. Agranulocytes include lymphocytes and monocytes. So the chart in your book on page 260 and 261 talks about the neutrophils, the eosinophils, the basophils, lymphocytes, and monocytes. So make sure you look at the function, because in your in your objectives, it says to compare and contrast the various blood types and how they're, oh no, not, we're back to identify the types of blood cells and function of each blood cell. So the function of the different white blood cells, so you want to check under neutrophils. They're highly mobile. They quickly migrate out of blood vessels and into tissue space where they engulf and digest foreign materials. Eosinophils are involved in allergic reactions. They also kill parasites, very different functions. Basophils secrete heparin, which prevents clotting in the infected area so white blood cells can enter. They also secrete histamine, a substance that causes blood vessels to leak, which attracts white blood cells. This is really important to understand as you're going into the pathophysiology and you understand how things work properly, you're going to see how this affects your body when things go awry. The agranulocytes, we have lymphocytes, are responsible for long-term immunity. Two types, T lymphocytes, which we talk about a lot in HIV, B lymphocytes, and they produce antibodies. Very important. Monocytes are the largest of the white blood cells, are highly phagocytic. They're big eaters. They can engulf large bacteria and viral infected cells. So these are the different functions of the white blood cells. And so go ahead and read the rest of the chart and note those important differences. So now we're going to move on to the platelets. Platelets are also called thrombocytes. They're clotting cells. They're the second most abundant of the formed elements. They play a key role in stopping bleeding, hemostasis. Platelets are fragments of larger bone marrow cells called megakaryocytes. The edges of the megakaryocyte break off to form cell fragments called platelets. Platelets live only about 7 days. So if you want to look at a little bit more about platelets in your book, it's on page 263. And we're going to be talking about blood clotting and platelets. So a question, a move to high altitude would trigger which change in the blood? We're going to see increased reticulocytes or decreased reticulocytes, increased neutrophils or decreased neutrophils. Well, we know reticulocytes are red blood cells and neutrophils are white blood cells. We know that going in. So reticulocytes are immature red blood cells. The body compensates for lower levels of atmospheric oxygen by increasing production of red blood cells. So your body registers that oxygen is lower, so more red blood cells are created. So the result of immature red blood cells would increase rather than decrease. But neutrophils are white blood cells, WBCs, and a change in altitude alone would not affect their rate of production. So keep that in mind so that that'll help you to understand the differences there. When a blood vessel is cut, so we're talking about hemostasis. So why we aren't just bleeding all the time or losing all our blood is because when a blood vessel is cut or damaged, the body must react quickly to stop the flow of blood. It does so through the following sequence of events. First, there's vascular spasm, the formation of a platelet plug, and the formation of a blood clot. As soon as a blood vessel is injured, smooth muscle fibers in the wall of the vessel spasm. So as soon as a blood vessel is injured, smooth muscle fibers in the wall of the vessel spasm. So that slows the flow of blood. So it's just like applying pressure as we do on the outside. So the next thing that happens is there is a formation of a platelet plug. The break in the blood vessel exposes collagen fibers. It creates a rough spot on the vessel's normally slick interior. This rough spot triggers and transforms passing platelets into sticky platelets. The platelets activate, and so they, as they're going around in the bloodstream, they're flat, and they pass each other by, and they don't stick to each other. But this rough spot triggers them to activate, and they become sticky, and they stick to the vessel wall and to each other, and they form a platelet plug. And the platelets facilitate clumping by secreting several chemicals. Some cause a vessel to constrict, whereas others attract more platelets. The platelet plug forms a temporary seal in the vessel wall. A more stable solution requires the formation of a clot. So this is the beginning procedure, the platelet plug. Now, for forming a blood clot, we have an extrinsic pathway, which is outside, or an intrinsic pathway, which is within the blood. So extrinsic is outside the blood, intrinsic is inside the blood, and both pathways end with formation of factor X, and that's what we're after, or factor 10. Blood clotting, coagulation, involves a complex series of chemical reactions using proteins called clotting factors. The first several reactions vary, depending on whether the process has been stimulated by factors either inside, intrinsic, or outside, extrinsic. When the damaged blood vessel and surrounding tissues, areas outside or extrinsic to the blood, release clotting factors, a cascade of events called the extrinsic pathway begins. When the clotting factors are activated within the blood, such as by the platelets as they adhere to the collagen in the damaged vessel wall, a cascade of events called the intrinsic pathway begins. The extrinsic pathway activates factor 10 through a single reaction. The intrinsic pathway requires 4 different reactions to activate factor 10. Once factor 10 is activated, the formation of a blood clot follows a common pathway. So the next thing here is the formation of a blood clot continued. Common pathway begins with production of an enzyme called prothrombin activator. The prothrombin activator acts on a globulin called prothrombin. You've heard of prothrombin time, factor 2, converting it to the enzyme thrombin. Thrombin transforms the soluble plasma protein fibrinogen into fine threads of insoluble fibrin. Sticky fibrin threads form a web at the site of the injury. Red blood cells and platelets flowing through the web become ensnared, creating a clot of fibrin, blood cells, and platelets. A blood clot can effectively seal breaks in a smaller vessel, but blood clotting alone may not stop a hemorrhage from a large blood vessel. So please view the animation on hemostasis. It is very clear in this animation, and it's a lot easier to understand. So please go through that animation. If you have to go through it a couple times, it's very clear. So we have the creation of a blood clot, but we also have a dissolution of blood clots. So after the blood clot forms, platelets trapped within the fibrin web contract. It pulls the edge of the damaged vessel closer together. After the vessel is healed, a chain of reactions converts an inactive plasma protein, plasminogen, into plasmin. And plasmin dissolves the fibrin meshwork and the clot breaks up. This process is called fibrinolysis. So we want to get rid of that once it's healed and don't need it anymore, and this process gets rid of it. So some of the things that discourage blood clots, we want blood clots to only happen when they're necessary. As your book says, one of the biggest problems is blood clotting and excessive blood clotting, and we want to have we want to have blood clots when we need them. We want to have enough blood clotting factors, and we want the process to be intact so that we will clot normally. But like it says on page 266, the formation of unwanted blood clots is the most common and perhaps the most serious of clotting disorders. In fact, about 650,000 Americans die every year from blood clots, and we spend a lot of time in the hospital trying to discourage blood clotting. So things that discourage blood clots are important because it's important to prevent formation of unwanted clots. some of that is due to like situations that we see in the hospital. People are immobile; they're not moving around. Blood is pooling, and we're not moving around. The circulation is slowing and sluggish. So a smooth endothelium prevents platelets from sticking. So we want to promote that. Normal circulation dilutes thrombin, which is normally present in small amounts. When the blood pools in the legs, such as during prolonged sitting or lying down, like you see in somebody who's in a hospital or nursing home, thrombin can accumulate and lead to clot formation. Basophils and mast cells secrete heparin, which blocks the action of thrombin. An unwanted blood clot inside of a vessel is called a thrombus. If a piece of the clot breaks off and circulates through the bloodstream, it's called an embolus. These are important terminology. You're going to hear this. A thrombus is a formation of a blood clot. An embolus is when part of that thrombus breaks off. It's loose in the bloodstream. There's nowhere for it to go. It's going to, because there's no outlet for it, it's going to circulate through the whole system until it gets to the smallest artery, and where it'll plug, and that's going to be the brain, the lungs, the heart, and where it's going to do the most damage. So smooth endothelium, a good blood flow, and anticoagulants will discourage blood clots. That's one of the reasons why we give Lovenox. It's a low molecular weight heparin, and you'll be administering a lot of that in your post-surgical patients because of how common it is for people to get blood clots after surgery. So what's the first step in hemostasis? Formation of a platelet plug, formation of fibrin, formation of a thrombus, or a vascular spasm. What's the very first thing that happens? It's D. A thrombus is an unwanted blood clot inside. No, the correct answer is D. D is vascular spasm. The rationale is a platelet plug occurs after vascular spasm, and formation of fibrin occurs even later during the formation of a blood clot, and a thrombus is an unwanted blood clot inside a blood vessel. So the first thing that happens is that spasm, that vascular spasm. That's the very first thing we're going to see. Now, blood types, that's your objective. Compare and contrast the various blood types and how they're used. So we're going to be looking at blood types. So we're going back to the red blood cell. And on the top, on the surface of the red blood cells, there are proteins, and they're called antigens. They're also called agglutinogen. There are two antigens, A and B. People with type A blood have the A antigen on their red blood cell. People with type B blood have the B antigen. People with AB blood have both A and B antigens, and people with type O blood have neither antigen. So if you look on page 266, it describes this, talks about blood types. Just a little fast fact here, 45% of the population has O blood, 40% has A blood, 11% has B blood, and 4% has type AB blood. That's why we say it's really rare. Okay, so let's look at these fellas here. Whereas the blood cell carries antigen, so that's the blood cell itself, the blood plasma carries antibodies called agglutinins against the antigens of the other blood types. Type A blood has anti-B antibodies. So you have A antigen, and which causes this person to have type A blood. They have anti-B antibodies. Type B blood has anti-A antibodies. Type AB blood has no antibodies, and type O blood has both anti-A and anti-B antibodies. So the thing about an antigen, which is explained on page 267, every cell in the body carries antigens on its surface. The antigen, they're unique to everybody. They allow the body to distinguish its own cells from foreign invaders. When the body detects a substance with an unfamiliar antigen, it launches an immune response to destroy it. This is very important. Antigens, every cell in my body is stamped with a little JLH, JLH. So every cell can be recognized. But if something comes along that changes that, then the body will attack it. And this is the basis of a lot of autoimmune disorders. But back to the blood cells, the first step in an attack occurs when antibodies in the blood plasma bind to the foreign cells or the cells containing the foreign material. Next, antibodies bind to more than one antigen molecule in an effort to corral the foreign invaders until the immune system can break them down. This process, which produces large clumps of antigen-antibody molecules, is called agglutination. So we're going to be talking more about the antigens and antibodies in the lymphatic and immune systems, but just kind of keep that in mind. Okay, so blood cells continued. Okay. If someone with type A blood were to receive a transfusion of type B blood, so this shows that the anti-B antibodies in the recipient's blood would immediately attack the donor's red blood cells. The antibody-antigen reaction would cause the red blood cells to clump together, and agglutinate means to clump together. So please look at the blood types and transfusion reactions animation. This will show you exactly how this process works and the importance of it. So we're going to look at Rh group because there is another classification. You have Rh positive or Rh negative. The Rh is from the rhesus monkey, and that's the first time it was really identified. So they if you had it, you were Rh positive, and if you didn't have it, you were Rh negative. So Rh positive blood contains the Rh antigen. Rh negative blood lacks the antigen. Blood does not normally contain anti-Rh antibodies, though, not like type A and type B. Someone with Rh negative blood develops anti-Rh antibodies after being exposed to Rh positive blood, either through a transfusion or when an Rh negative mother becomes pregnant with an Rh positive fetus. If someone with Rh negative blood receives a transfusion of Rh positive blood, the person's body interprets the Rh antigen as something foreign, so the immune response is activated. To protect itself, it develops anti-Rh antibodies. If the person receives a subsequent transfusion of Rh positive blood, the anti-Rh antibodies formed during the first transfusion will attack the Rh antigen in the donor blood, causing agglutination. So this is explained on this about the Rh group, and that's on page 268. Now, this shows, and we're going to go over this a lot more in Mother Baby, but it's going to help you to understand this, that what happens is if a mother who is Rh negative has an Rh positive baby, because the father is Rh positive, so the baby is born with Rh positive blood, and while the baby is inside the mom growing there, the blood does not mix. The first pregnancy with an Rh positive fetus will proceed normally. During delivery or miscarriage, the fetus's blood mixes with that of the mother, thus introducing Rh antigens into the mother's bloodstream. So the first baby is not affected, because the blood hasn't mixed, and and so the Rh antigens haven't gone into the mother's bloodstream, so she hasn't developed antibodies. But what happens is the mother's body responds by forming anti-Rh antibodies against this foreign substance. So the next pregnancy with another Rh positive baby, the anti-Rh antibodies pass through the placenta even if the red blood cells can't. So the antibodies can get through there. So the blood is not mixing. It's just that the antibodies can pass through and they attack this fetal red blood cells. It causes agglutination and hemolysis, and the infant develops a severe anemia called erythroblastosis fetalis. So please view this animation of the blood Rh group, the Rh antibodies, and erythroblastosis fetalis. It'll be very good information for you. It'll help you in the future when trying to understand this condition in infants. So the question is, what substance carried by each red blood cell determines the blood type? Is it an antibody, an antigen, a hemoglobin, or a globin? It's an antigen. Okay, so this concludes this chapter 13, and we're going to go on with chapter 14 next.